Great. Am I audible or am I breaking? I'm being told my internet is unstable. Anyone? We are just 7 individuals here, so if you're waiting for your friend to unmute, it's you we are waiting for to unmute. Am I breaking or am I not breaking? You can even just write it on the chat box. Let's start then. All of the following are live attenuated vaccines, except all of the following are live attenuated vaccines, except you have polio vaccine, measles vaccine, BCG vaccine, and tetanus vaccine. So the tetanus vaccines, it's a toxoid. So on vaccines, what do you want us to cover? What vaccines are administered at birth, 6 weeks, at 10 weeks, at 14 weeks? And what classes are they? Yeah, so please unmute. Please unmute. If you're, I won't. I'm not going to lead the discussion. I'm just steering the discussion. So, vaccines. What do you know about vaccines? Okay, saying at birth, the MMR.
I think at birth we give the BCG usually most of the time because we want to protect this kid against or the child against tuberculosis. BCG.
Yeah, BCG. Yeah. I think no BCG. Okay, I don't know where. Maybe perhaps we may have studied in different places. So, but according to the Kenyan guidelines, I'm asking according to the Kenyan guidelines, what vaccines are administered when? So at birth is BCG, and also we have the polio vaccine. Any other vaccine administered at birth?
I think at birth it's just those two, BCG and polio.
And anything else given at birth? There's something we mentioned last
Can you
week
give
that.
hepatitis B?
No, I think at birth you also give vitamin K because these kids don't have the capacity to have their own vitamin K at birth. So we give vitamin K at birth.
Yeah, nice. Vitamin K. Yeah. Kitu ingine? I think we are done with birth at 6 weeks. is saying tetanus at 6 weeks.
I think also at 6 weeks means after birth and after every 4 weeks there is this pentavalent, but I'm not so sure of the combination of the pentavalent stuff. But it's also given.
Which are pentavalent.
Pentavalent, I'm not so sure what it has, but it's also
Uh-huh.
given. Plus, I think the whole PV also, the all polio vaccine. Because oral, remember we have the OPV, we can have the Sabine or the SALC. Yeah. Sabine, the SALC being the other one.
Can you tell us more about the classification of Sabine and Salk? Because one, they are classified differently. Anyone else? Polio vaccines, is the Sabine and the Salk. Are they different or it's one and the same thing?
Sorry, I went off a little, but what I know with Sabine is the oral vaccine and usually live attenuated. But for the SALC, it's not given via oral, but I'm not so sure if it's live attenuated or killed vaccine. I'm not sure.
She's not sure. Anyone who's sure. Want to cover vaccines, right? Now we get done with vaccines. Sahi. And if someone has the immunization guidelines, they can share on the group. I'm looking for them on my side currently. But if someone has them, they can share on the group. Well, some is saying Sabine is the oral one.
Guys, are you talking about the Kenya National Immunization Policy?
Yeah.
Okay, let me share on the group.
Great.
Yeah, Sabine is oral and it's usually given like within an interval of 4 to 6 weeks. And then there's usually a booster dose, which is 1 year after the initial doses. Then after 5 years.
Okay.
And it's live attenuated.
So what about Salk?
Which one, sorry?
Is it live? Is it inactivated? Dr. Karimi wasn't 100% sure, so I want us to confirm.
For which one?
The Salk.
Oh,
Yeah.
let me check.
So here's the schedule. So just to repeat what you've been saying, at birth we just have two, or three in quotes. We have BCG. We know it's intradermal. We have the oral bleeding. That's at birth. Then at 6 weeks, we have PPT, which has been combined with influenza B, HIV. So based on, then we have the PCV, I think that's the pneumococcal vaccine, and the rotavirus. Let's just confirm from the key. Hope there's a key. From this, Salk is inactivated. Great. So Salk is inactivated. Sabine is the live attenuated. Sasa on this, DPT, Hep B, Haemophilus, influenza B. Comment about this. DPT, what does it protect against? DPT, Hep B, Haemophilus, influenza, yeah. Anyone?
I think for DPT it would be the diphtheria, then P would be pertussis, and T would be tetanus.
Yeah, nice. The diphtheria, we've already said the tetanus is a toxoid. The diphtheria and the pertussis, what type of vaccine are they? The question is for everyone, it's not for the person who's just answered. Diphtheria, is it live attenuated? Is it a toxoid?
It's a toxoid.
It's a toxoid.
Yeah, I think.
Okay, yeah.
But I think it's inactivated surface antigen. Or is that the same as toxoid?
I'm not sure.
So it means toxin whose toxicity has been inactivated.
So just I'm finding here from the reference, yeah, diphtheria, as Dr. Karevi said, is a toxoid. Even the pertussis is a toxoid, the tetanus is a toxoid. Yeah. Then the Haemophilus influenza type B is a polysaccharide. Now for the hepatitis B, what is it?
It's inactivated.
Activated. Hiral, nice image, summarizes this. So on the group, Hiral has sent the diseases and the types of vaccines that are there. So pertussives, we are seeing here, it's under the microbial extracts or products of pathogens or toxoids, yeah. I think that image summarizes everything. Hepatitis B inactivated surface. You can see the sabine being an attenuated pathogen. Based on that image, I think we can move. Unless someone has something to add. Number 26, a complement system dash is involved in opsonizing and lysing organisms, releases histamine, is composed of immunoglobulins, is only found in children. A complement system, what does a complement system do? Is it only found in children? Is it composed of immunoglobulins? Is it involved in opsonizing or lysing organisms, or it releases histamine?
A would be right, according to me. Reasons being, when we were talking the last time, we talked about the three different pathways. We had the classical, alternative, and the lectin pathway. And what we saw is that we had a convertase C and a convertase 5, I mean C3 and C5. Whereby the C3, when it's broken down by the convertase, we will get the C3A and C5B, which are usually C3A and C5B would be more for inhibition, but the C3B will be for opsonizing, means it's the one which is marking the microorganism, so that now the mark that the membrane attack a complex can punch holes and kill the microorganism or the cell infected. So A would be right.
Yeah, A would be right. Thank you. I think
B.
as she said,
So the effect of complement system is that it releases histamine and basophils. That's what from mast cells. So it doesn't
yeah.
just use histamine like it uses both histamine and basophils. I don't know if that makes sense.
Kindly repeat, Fatma.
So I was saying the activation of, to summarize, the activation of complement system, it causes agglutination. Agglutination is like it makes the bacteria tasty so that it can eat it. Then there is bacterial opsonization. There is chemolysis, where it causes the inflammatory mediators to the site. And also there is direct killing, which is the lysis, as was said. There's also neutralization of the viral toxins. It makes like it converts virulent to non-virulent. And also it causes release of basophils and histamines from mast cells.
Yeah. Oh, thank you. Great. Then for the complement system, because I think last time we extensively discussed the complement system, all the three pathways, and we said we will not be repeating something if we've already taken time there. Unless someone has a question on the complement system, we shall move. So next question is an example of type 2 hypersensitivity reaction. We have serum sickness, allergic rhinitis, Graves' disease, or rheumatic heart disease. So what's an example of a type 2 hypersensitivity reaction?
The type 2 is the rheumatic heart disease.
Rheumatic heart disease. Uh-huh.
And then serum sickness is type 3. Allergic rhinitis is type 1, and Graves, I think it's I'm not too sure about that one. Someone saying Graves is type 2 also. Type 2.
Yeah. I also thought the same, that Graves is also a type 2.
So then rheumatic heart disease, there's one that is
No, even rheumatic is a type 2.
so
But rheumatic arthritis is type 3. Maybe you're confusing with
Rheumatic
that.
is the heart disease.
Heart disease is type 2. Arthritis is type 3. So there are two possible answers here.
Meanwhile, then you say there are two possible answers. Someone can talk about the hypersensitivity reaction, type 3 to type 1 to type 4. What are the different types of hypersensitivity reaction? What mediates them? What are the other examples? You said already, allergic rhinitis is type 1, serum sickness is type 3.
Okay, I can talk about it. So hypersensitivity, we have 4 types. We have type 1, type 2, type 3, and type 4. You can hear me?
Loud and clear, loud and clear.
Okay, so as I said, we have 4 types of hypersensitivity reactions. We have type 1, type 2, and type 2, type 3, and type 4. So type 1 is IgE mediated, and it's also called allergic reaction. Type 2 is also called cytotoxic hypersensitivity and is mediated by IgG or IgM. Type 3 is the immune complex mediated, and it's also called antigen antibody reaction. And then type 4 is called delayed type reaction, and it's mediated by T cells. Yeah, it's mediated by T cells. So an example of type 1 can be fever, anaphylactic reaction, asthma. Type 2 can be hemolytic, anemia, Graves' disease. Type 3 can be SLE, rheumatic, you've said rheumatic arthritis and serum sickness. Yeah, then type 4 can be TB or contact dermatitis.
Thank you so much.
Is rheumatic arthritis and rheumatoid arthritis the same?
No, it's not the same.
So rheumatic disease, what is it? There's rheumatic heart disease, and then there's rheumatoid arthritis. Okay, never mind.
Yeah. Okay. So this or
The question is
the
question is asking for type 2 or type 3. Because I don't think it's clear.
it was asking for
If it's 3, then the correct answer is A.
Yeah. That makes sense. That it was asking for type 3. Yeah, so type 3, someone has sent a good mnemonic on the chat box as a photo. Please check it out. Check it out. So we've seen allergic rhinitis. It's type 1, as I said. IG mediated. Type 2, we've seen crisis of newborn. Yeah, type 3, we've seen serum sickness. She's also talked about the rheumatoid arthritis now comes first. That is on type 3. Type 4, contact dermatitis, the TB, wherever you see TB, that's type 4. And also the Steven Johnson. Then I think she already type 4 as a sensitivity reaction is mediated by, she mentioned that it's mediated by T cells. Yeah, mediated by T cells. Reaction, CD4 cells in the in the body is to do what? Body mediated immunity. Sorry, I got disconnected. Cells in the bodies to do what? What's the role of CD4 cells? Is it to stimulate cell-mediated immunity only, stimulate antibody-mediated immunity, release cytokines, or stimulate both the cell and the antibody-mediated immunity?
The role of CD what?
CD4.
Cell-mediated.
Cell-mediated only.
Yeah, because antibody is the B cells. CD8 is in T cells.
Maybe what I remember slightly is that the CD4 is the one responsible for stimulating the B cells to function. And at the same time, it also stimulates the CD8, the cytotoxic T cells to act. So I don't know if we say that cellular, will be talking of the CD8, or we'll be talking of general the T cells, but it is responsible for stimulating the B cells to function, at the same time the CD8.
Dr. Karim has said that it does stimulate both the T cells and the B cells. So it stimulates both the cell mediated and antibody mediated. Anyone else with a different view? Or not view, or different answer? Something more on immunology. We've talked about the hypersensitivity reactions. Can someone now mention on the CD4 cells, and another person to talk about the CD8? Then another person will talk about the T regulatory, because we know they're all classified as T cells.
So for CD8, they're usually involved in cell-mediated immunity, and they usually interact with MHC1 molecule of the T cytotoxic cells. So when these interact, they usually cause they release perforins and granzymes, which now kill the bacteria. Yeah.
Nice. So she's talked about CD8 will interact with the MHC1 and directly lyse the cell through releasing the granzyme and perforin. On CD4, what role does CD4 play in the immune system? Apart from just activating this, does it have any other role?
It leads to activation of T helper cells. The CD4, they're actually found on the surface of T helper cells, and then they bind to an antigen presenting cells like dendritic cells and macrophages, and they lead to major MHC2 complex activation, so, which will activate T helper and initiate the immune responses.
Nice. So HIV targets CD4 cells. Why? What's the effect of HIV on these CD4 cells? How does HIV gain entry? We can't talk about CD4 and not talk about HIV.
I think HIV usually destroys CD4 cells, thus making the immune system unresponsive to the infection, because we have said the CD4 cells are the ones which activate cell mediated and antibody mediated.
Yeah. Also on that, Betty is adding that CD4 cells also produce cytokines. So on HIV and CD4 cells, are there any drugs that can target or that can inhibit by HIV?
Guys, please repeat.
Since we've said that HIV infects the CD4 cells, are there any drugs that inhibit the entry of HIV into the CD4 cells?
Yes, because like looking at the classification of antivirus, specifically the HIV, we can have those inhibiting the attachment and also inhibiting the co-receptor CCR5. So the ones to inhibit the CCR5 will be somebody has already posted Maraviroc, and then we have enfivatide for entry inhibitors.
Yeah.
But you can also have others which are inhibiting the attachment. You can also have another inhibiting the attachment or stimulvia, something like that.
Yeah, nice. So she's even gone ahead and talked about the CCR5. Yeah, nice. Friends are more likely to get active TB than non-HIV patients. What role, what's the interaction? Anyone? What's the interaction between HIV, CD4, and TB? Why do we see TB in HIV patients? What's the mechanism behind it?
As someone noted earlier, when you have HIV, there is destruction of the CD4 cells, and looking at them, they are cells of the immune system. So the moment they are attacked and you have very low CD4 counts, then your immune system goes low. And remember, TB is a disease which everyone it's like you have it, only that it's not activated until maybe something triggers your immunity or somehow. So in issues of HIV, the immune goes low, and usually you find it at stage 4 of HIV, whereby the immune status of this person is damnedly compromised, then the person is susceptible to TB. Yeah.
Yeah, nice. So most people have TB, latent TB. You may have TB, I may have TB, and it's somewhere in the lungs enclosed by macrophages, and these macrophages are activated, or they remain activated by CD4. So if you attack the CD4, the macrophage stop being active, and TB moves from being a heavily guarded prisoner to being a prisoner that is free to roam throughout your body. Hence, hence why a patient with HIV is likely to get TB. And now on this, because I don't think we'll have time, what is treatment of TB? How do we treat TB? Because we've mentioned TB.
Okay, so TB has two treatment phases, the intensive phase and the continuous phase. The intensive phase is for 2 months. Yeah, 2 months, and usually for drugs that are given, that is isoniazid, pyrazinamide, rifampicin, and ethambutol. Those are given for 2 months, and then the continuous phase is for 4 months, and it's usually two drugs given, that is isoniazid and rifampicin, I think. Yeah, which is for 4 months. So the total duration is 6 months.
Yes, maybe can I add something little on the same? That's true, but that will be for pulmonary TB. In case of extrapulmonary TB, something like brain TB or bone TB, the continuation phase may go up to 6 months or even 8 months, depending on extrapulmonary, which part is being affected. Yeah, thank you.
Yeah, thank you so much. Yeah, so yeah, majorly the 6 months is for the pulmonary TB. When it comes to the other forms of TB, it now depends on the affected area, such as if we have the brain TB, or which is called tuberculous meningitis. Yeah, I think the therapy is yeah.
I think we say that for the first isoniazid in those ones, ethambutol is the only one that's bacteriostatic. The others are bactericidal, right?
Yeah, nice, yeah. Let me just it's typically 12, as Nani has said, that the pulmonary TB is the one treated for 6 months, 2 months intensive, 4 months continuation. Patients it is patients with CNS, 2 months intensive, months continuation. You're seeing TB in the bone again is treated with for 9 months. So just to repeat what she said, it depends on which area is affected. But since the lungs are the most affected, we'll repeat that. 2 months intensive, 4 months, we have the continuation. And I know you know the drugs, the side effects, patient advice. We're not going to go there at this time. So next question. All of the following are autoimmune diseases, except which one is not an autoimmune disease? Myasthenia gravis, rheumatoid arthritis, I think, and non-insulin dependent diabetes mellitus. Of course, based on the choices, we have two opposing choices, B and D, insulin dependent or non-insulin dependent. Between them, which one is not an autoimmune disease?
Non-insulin dependent.
Non-insulin dependent. What's the other name for non-insulin dependent diabetes?
Type 2 diabetes.
Yeah, type 2. And we know type 2 is mostly lifestyle associated, right? So rheumatoid arthritis, insulin dependent, that is type 1. Myasthenia gravis. Can someone just mention what what is the autoimmune process in myasthenia gravis, and how do we treat myasthenia gravis? In less than 30 seconds. What happens in myasthenia gravis and how do we treat it?
Hello. I don't know if you guys can hear me.
Loud and clear, Dr. Sam. Loud and clear.
Great. Okay, so in myasthenia gravis, we usually have antibodies targeting the acetylcholine receptors, the synaptic terminals of the nerves. So they usually cause damage to these nerve cells. As a result, the nerve cells become resistant. They're not stimulated by acetylcholine. So usually diagnosis, I think they usually use hydrophonium. And then for treatment, they use drugs which are going to increase the residence time of acetylcholine in the synaptic cleft. So basically the acetylcholine esterase inhibitors, for example, paridostigmine, etc. Yeah.
Yeah, nice. Yeah. Just on the chat box, yeah, nicotinic receptors, yeah. So, yeah, I hope myasthenia gravis, you won't forget again, right? Antibodies target the nicotinic receptors. So, if we are targeting nicotinic receptors and destroying these receptors, what is a symptom of myasthenia gravis?
I think the patient will have impaired speech, difficulty in swallowing, trouble in breathing, muscle weakness.
Yeah. Muscle, yeah. All of those symptoms really as a result of muscle weakness. Yeah. Nice. Then finally, what type of, based on even the explanation Dr. Sam has given us, what type of hypersensitivity reaction is it? Is it type 1? Is it type 2, where antibodies are attacking on the surface? Is it type 3, where the immune complexes are being deposited somewhere? Or is it type 4, hypersensitivity reaction?
Type 2.
Nice. Type 2, yeah, you're right. So type 2, yeah, hypersensitivity reaction, yeah. But that's Shrina, whenever you're ready to share your screen, just tell me. I know well, I'm not the best. I don't write all of these notes down.
Right now, I've just joined and I'm writing with my hand. Then I can share it as I'll just share my notes. I'll scan them.
Nice.
Yeah.
Number 31, Ascaris lumbricoides. Dash, is it a cestode? Does it cause Weffler's syndrome? Is it transmitted by fly? Can it cause cysticercosis? Is it cysticercosis or cysticercosis? Ascaris lumbricoides. What is Ascaris lumbricoides?
B would be the answer because it's a nematode.
B would be the answer.
Yeah.
Yeah, nice. It's a nematode. And how is it transmitted?
It's through ingestion or fecal or
Yeah, nice. Fecal oral. Yeah. Any treatment? How is it treated? What do you give? Mebendazole. Nice. Then on this, who can mention the other nematodes, trematodes, cestodes? Examples. What are the examples of those? Just examples of the cestodes and examples of trematodes. Examples of nematodes. Any that you know. Examples of cestodes.
Nematodes are roundworms, so include Ascaris lumbricoid and hookworms. For Ascaris lumbricoid, it's transmitted through contamination, food and water, the eggs. And then there is for trematodes, that's the flukes, the cystoma species. And then it's transmitted through skin and contact with water. And for the cystoma, there is cystoma hematobium and Mansoni. The one hematobium affects the human urinary tract, and the other one the blood vessels. Yeah.
Yeah, nice. So I think last time we discussed a lot on the okay, is also adding that cystodes, we have the Tinea species, the Tinea solium, Tinea saginata, such things.
Can I also inquire on something? What is this Werfler syndrome? And then I would also wish to add something on nematodes. When you talk of ascaris, when you talk of Streptococcus trichuris and cystoma, those are intestinal nematodes. But you also have blood nematodes and blood and tissue nematodes. That's when we talk of things like Buncheredia bancrofti, it is a tissue nematode, usually in the lymphatic system. Also, when we talk of things like Brugia malai, when we talk of things like Onchocerca bulboris, also they are nematodes, but either in the cavities or in the subcutaneous tissue, or in the cavities or lymphatic system. So on the nematodes, you can have intestinal nematodes, tissue nematodes, or the blood nematodes. Yeah, thank you. So what is this Werfler syndrome? I don't know.
Let me just send this on the chat box. I believe it was just a spelling error, but the right name is Loeffler's syndrome. It's the Loeffler. So it's the period whereby when the worm, we know the worm gets into the stool. You get it orally, but it does escape and go to the lung first, and then you swallow it again. So that period when it's in the lungs, there'll be some sort of cough, some shortness of breath, some pneumonia-like symptoms, even some fever. That is what we call the Loeffler syndrome.
Thank you so much.
Welcome. So Number 32, Leishmania donovani is transmitted by, I don't know if this question has been repeated, but we had already covered this in the previous discussion, and we even mentioned the other diseases transmitted by the various organisms listed here. So real quick, someone to remind us, just the 3 that are listed here: the chiroswabs, the Anopheles mosquitoes, and the red bugs. Which disease do they transmit? Just quickly, because we already mentioned them. I don't want us to go and look at them again. Anopheles mosquito. Hadi hiyo hamtaki kuadmute. Hadi useme Anopheles mosquito ina transmit nini?
In what I remember for chrysops, this is a type of a fly which usually causes the loa. When you look at Anopheles mosquito, you know it's usually for malaria. Then Ludividi bug, it's also the triotine bug, which usually causes trypanosomiasis, but not the African trypanosomiasis, the other one.
Yeah, the Trypanosoma cruzi. Yeah. So because we've covered this, we'll be flying past what we've covered before, so that we don't spend a lot of time on the same topic twice. So meningoencephalitis may be caused by, is it Naegleria fowleri, Entamoeba histologica, Entamoeba coli, or Giardia lamblia? Meningoencephalitis. What's the causative agent on the choices? What's the causative agent of meningoencephalitis?
I think by elimination we'll have to go with A.
Naegleria fowleri. What can, not necessarily some, but what do you know about Naegleria fowleri? Anyone? Is it a bacteria? Is it a fungus? Is it a parasite? Is it an amoeba? Is it, what is it?
It's an amoeba.
Mm-hmm.
And one thing that's different about it from the other, like E. histolytica, it's that it has like a flagellate form. The other have trophozoites and cyst, but then something different about yeah, it has a flagellate form, and it causes the Koenig sign. Like to diagnose, yeah. Yeah.
Nice. Causes the Koenig sign, it's flagellated. It's a free-living amoeba. Samia is saying that it's also known as the brain-eating amoeba. Okay. So the next question is, how do we treat it? We've mentioned what it is. How do we treat it?
They can be treated using amphotericin B, and also we can use rifampicin, although they are like rifampicin is for mycobacterium, and also looking at amphotericin B, it's more on antifungal, but it can also be used to manage the condition.
Yeah, nice. The ampho-B and rifampicin. Usually, okay, what I know mostly I've seen ampho-B is the major agent being used. I'm not to have you, Dr. Karim, have you seen rifampicin being used or in the guidelines somewhere? It's just on the textbook.
No, not in the guidelines. In the guidelines, I am aware of amphotericin B, so I would go for the amphotericin B instead of rifampicin. Yes.
Oh, okay. Yeah, but yeah, and the addition of this they can also be considered. This is just on the treatment for Naegleria fowleri. High dose amphotericin and the addition of azoles. Rifampin will rather should be considered. The other free-living amoeba that we are seeing here is the Xanthamoeba. Who can remember what Xanthamoeba causes or what is even it's written here. Keratitis, right? Usually Xanthamoeba, you'll see it with people who are not patients who wear lenses and now they have not really observed that accept those aseptic techniques, hence you see Xanthamoeba can come in there and she's treated with the topical chlorhexidine or the polyhexamethylene. Okay. We move. Unless someone has something to add on that.
Yes.
Yeah.
This one, acanthamoeba, it's the one that it causes keratitis to those who are wearing contact lenses mostly, right?
Yeah.
And could you please share for us this book in the group?
I will think about it. Next question. Hep B virus. Hepatitis B virus. Is it a DNA virus? Is it an RNA virus? Is it transmitted through oral fecal route? Or is it transmitted through droplets? Hepatitis B. I think hepatitis, we took considerable amount of time to go through them. Yeah, someone has already written on chat book that all hepatitis virus, all hepatitis virus are RNA virus except for hepatitis B, which is a DNA virus. Yeah, then we took our sweet time. So hepatitis B is a DNA virus. All the other ones, Hep A, Hep C, Hep D, Hep E, they're all RNA viruses. So we move because I think we've discussed hepatitis in depth before. Unless someone has a question or something to say on hepatitis. Number 35, herpes zoster is caused by, let me see, there's something in the chat box. Yeah, okay, has already answered. Herpes zoster is caused by yeah. I think also the herpes viridae family, we've also discussed them in detail while we are doing another paper. So see, we are reaping the fruits of covering this stuff in detail before. Does someone has a question on number 35, something to add? You know, you may see something and have something to add. Moving on. Scalded skin syndrome is caused by someone already said Staphylococcus aureus. Aureus. Shrina, I'm not so sure, but I believe we took some time and discussed Staphylococcus and Streptococcus in a previous discussion session. I'm not so sure.
Yes, we did.
True.
We did.
We did. So we can move.
Yeah.
Okay, that's great. Streptococcus pyogenes causes necrotizing fasciitis, is a gram-negative bacteria, is anaerobic, or is it a spirochete? strepiogenes. Yeah, we are having, yeah, everyone is saying A is the answer. A is the answer. Yeah. Necrotizing, fasciitis or fasciculitis. Yeah. The flesh-eating bacteria. Yeah, we already say a gram-positive, facultative, anaerobic. It's not a spirochete. What's an example of a spirochete? Don't think we've discussed spirochete before. What's an example of a spirochete?
H. pylori na treponema.
Yeah. H. pylori, treponema, pallidum. H. pylori, we've discussed. So treponema, tell us about treponema.
Well, it's the causative agent for syphilis.
Causative agent for syphilis.
It's a spirochete alafu, yeah, si ni hivyo tu, maybe treatment, but yes.
Treatment. Treatment of syphilis. Maybe someone is suffering and they've been waiting for this moment.
Pen G. Money pen V. Pen G.
Yeah, the intramuscular pen G. Nice.
Yeah.
And what's the alternative? If someone is allergic to penicillin, what can you give?
Sick or sure.
First generation cephalosporins.
First generation cephalosporins. That is, yeah. If it's not a type 1 hypersensitivity reaction to penicillin, what if it's a type 1? We know for type 1 hypersensitivity reactions, you can't even give a cephalosporin because of the cross reactivity.
Erythromycin.
Pardon?
Erythromycin.
Erythromycin. I'm not sure. Oh, what I know is that the treatment, if someone is allergic to penicillin, they give doxy. You'll give doxycycline. Maybe we confirm on the if a macrolide is effective against syphilis.
There was also another drug called spectinomycin, but I can't remember the class. It's something like a glycopeptide. It isn't a penicillin, spectinomycin, and it was used whereby it has been in use where patient is allergic to penicillin, spectinomycin.
It's an yeah. Yeah, it is. Primary syphilis, just give them the 2.5 4 million units AM, they're good to go. Alternative doxy or staph or yeah. So I think this is a summary for management of syphilis. Then one last thing for treponema pallidum or for syphilis, what's the symptom? How will you know this person has syphilis?
Painless chancre that disappears, yeah, after a certain period of time.
Yeah, nice. A painless chancre that yeah, will disappear after a certain period of time. Then secondary syphilis, you can see the chancre there. The chancre will have exposure where syphilis first got in touch with. Right. Sam, you're saying secondary syphilis? I don't know if it's my internet or anyone else, secondary syphilis, because we've divided into primary, secondary, and tertiary syphilis. So what will be the presentation in secondary syphilis? Yeah, Betty is saying maculopapular rash. Yeah. Yeah, this patient will now come back complaining of rashes all over the body or some parts of the body. Doesn't have to be as
How about
perfectly
swollen?
distributed as here. Yeah, can be anywhere. Uh-huh.
How about swollen lymph nodes?
Yeah, swollen lymph nodes. Yeah. It's yeah, definitely there'll be this. And then finally, tertiary syphilis. Primary syphilis will come. The patient will say they had a sore, and then it went. And then the rashes will come, and then they'll disappear. So finally, this patient will come to you, for example, with tertiary syphilis. So tertiary syphilis, what are the symptoms? Or what happens with the tertiary syphilis?
I think the common thing in tertiary syphilis, you see granulomatous lesions, which are usually called the gumas. And it's like a lesion filled with pus and other things. Then which later, if the thing is not managed, this patient may end up in having congenital syphilis, means it will have moved to the CNS, now bringing other complication of the immunosyphilis.
Yeah, nice. It gets to the tertiary stage, it can affect any organ, can affect even the liver. You can see there are three main types: the neurologic, cardiovascular, and the gammas, which is characterized by this benign sort of regions all over the body. Yeah. You should talk about the last form, or the other type is the congenital syphilis. Yeah, whereby it can lead to the neonatal death, even abortions. Yeah. And you can see the treatment, again, just to take you back to the treatment, is that simple. If it's a primary syphilis, the start dose works well. Secondary also will work well, and if it's in the early latent phase. But if we're in the late phase, or we are now reaching neurosyphilis, you can see the different treatment regimens all over. Yeah, I think we can continue. Which of the following does not cause food poisoning? Salmonella species, Bacillus cereus, Clostridium perfringens, or Streptococcus pyogenes? Someone has already tweeted and said that the answer must be Streptococcus pyogenes. Right? Streptococcus pyogenes. Anyone with something to note on food poisoning? You know, food poisoning is a major thing, right? At some point, it's statistically speaking, everyone in their lives will get food poisoning at some point. So yeah, food poisoning. If you've never gotten food poisoning, know that statistically you get food poisoning in the future. So how will you know it's food poisoning? What are the symptoms of food poisoning? what are the causative agents of food poisoning? How do you manage food poisoning? Do you give antibiotics very fast?
There are several causative agents. There is Salmonella, E. coli, Listeria, Clostridium. There's also Staph aureus. And symptoms obviously is diarrhea, abdominal pain, cramps, nausea, vomiting, sometimes headache, loss of appetite. And I don't know, treatment, it depends. So it's the severity of diarrhea. If there's too much diarrhea, you can give antidiarrheals like loperamide, and then you need fluids. What do we call this? ORS, to compensate the loss of the loss of the fluids that were lost from the body. Yeah, that's the only thing I know. For the dehydration, yeah, to compensate the dehydration, for the ORS is to compensate for the dehydration.
Nice. So she's talked about the symptoms, the abdominal pain, diarrhea, vomiting. Of course, it will depend on which type of food poisoning, or what's the causative agent of your food poisoning, right? Treatment majorly at the center of treatment, it's the ORS, oral rehydration ORS. What's the S stands for? Oral rehydration salts, I think, oral rehydration therapy. Yeah. Then the causative agents, all of them, you can see here, we have the Staph aureus, the Bacillus cereus, Clostridium perfringens, Vibrio cholerae. I think we all know Vibrio cholerae can cause the E. coli, the Salmonella species, the Campylobacter, Shigella species, and the Vibrio parahemolyticus. Yeah. So I think this table really summarizes food poisoning. What are the bacteria that cause? What symptoms will we expect? And also, what are the common food sources? What are the common food sources of these types of food poisoning? So let me just send this picture to the group also while we are at it. So one last question is, do antibiotics have a place in management of food poisoning? I think right now in the field, anytime anyone gets food poisoning, they're just given the secnidazole stat. So my question is, do antibiotics have a role in management of food poisoning? Anyone? Yeah.
Okay, I think usually they say don't give antibiotics because due to the diarrhea, and yeah, it's supposed to basically clear the causative agent. But I think in some cases, then might actually be given antibiotics.
But let me now. My next question then is: if you're given log, is it the start dose? In short, I'm simply asking: is this the giving of secnidazole for food poisoning? Is it indicated? Is it the right thing, or Is it the wrong thing? Not solution, not solve solution.
Is it given as an empiric therapy? Because how do you give secnidazole without giving the oral dehydration? Already the patient has dehydrated. And
I imagine they just give 2 grams secnidazole and they tell you you'll be fine. And it's a common practice. It's a very common practice. Even these days when people get food poisoning, they just come and take the secnidazole over the counter. Usually they buy it from Dr. Sam from Kabarak. It's very unethical. Anyway, that's the assignment. Let's go to the next question. The main cause of meningitis in HIV patients. What's the main cause of meningitis in HIV patients? Is it Cryptococcus neoformans? Is it the Candida albicans? Is it the Histoplasma capsulatum? Or is it blastomycosis? The main cause of meningitis in HIV patients, what is it?
Cryptococcus.
Cryptococcus neoformans. Tell us something about Cryptococcus neoformans. Anyone? Doesn't have to be the person who has answered. Cryptococcus neoformans. What is it? Is it a bacteria? Is it a virus? Is it a fungus? How do we diagnose it?
It's a fungus.
It's a fungus.
It's commonly found in soil and decaying vegetations, and it gets into the body through inhalation of fungal spores. And it's the most life-threatening condition for immunocompromised patients, like the ones with HIV. And some of the symptoms are fever, headache, blurred vision, neck stiffness, altered mental status. For some treatments, you can use antifungals like amphotericin B and fluconazole. But is fluconazole, does it cross the PPB?
Yeah, in the case of,
Yes. Okay, then you can use fluconazole. I was doubting that.
Never doubt yourself. You're a pharmacist. You never doubt. You're a professional. Nice. So, yeah, she's talked about the symptoms, the treatment, the causative organism. What about diagnosis? There's something unique about the diagnosis of cryptococcal meningitis.
They
How
use
do we diagnose?
the cryptococcal antigen detection. Was that the answer you were looking for, guys?
Yeah, the cryptococcal antigen test. Am I breaking? I'm being told my internet is unstable.
No, we can hear you.
Or am I breaking?
No, it's okay. You're okay.
Yeah, the cryptococcal antigen test.
Also the CSF analysis. The cerebrospinal fluid, you can do a lumper puncture to it and then you analyze it.
Yeah.
And then there's the Indian ink staining, whereby the cryptococcus fungi are visible and encapsulated yeast cells surrounded by a clear halo. I don't know what a halo is.
A halo.
What is that?
It's a circular nini. Let me see, like a halo. I don't know. I wasn't in SIU. Let your SIU people explain the English.
I think it's like a ring around that, like a colony or whatever. Not a colony, but around that fungi.
You see, your SIU people know this thing. A ring, yeah, saying around thing. Yeah. Then something unique about the cryptococcal antigen test is that it can remain positive even months after someone is treated of the cryptococcal meningitis. So a second test may not be reliable. It may still be positive, whereas the infection may not be cryptococcals or cryptococcus. Yeah. Then, oh yeah, these are the fungus, Candida albicans. What does Candida albicans cause? I think at no point have we talked about mycology. Candida albicans. Someone in the chat box is saying diaper rash. Head diaper rash. Anything else? Candida albicans.
Oropharyngeal candidiasis and vulvovaginal something.
Someone in the chat box is saying that thrush causes thrush. Yeah.
And
What?
the vulvocandidiasis.
Yeah, the vulvovaginal candidiasis, VVC. So how do we treat Candida albicans? We've said the condition causes. How do we treat Candida albicans?
I think for the vulvovaginal and apenanga to 150 milligram fluconazole, just one tablet.
Yeah. One tab, or rather 150 mg start of fluconazole. That's we've treated the vulvovaginal candidiasis. What about the oropharyngeal candidiasis, and then also the esophageal candidiasis? How do we treat? Someone has come with the oral thrush. The tongue is all whitish and stuff.
Can give nystatin.
Yeah, nice. The nystatin suspension, the oral drops. What about the esophageal? Oh, and how is the nystatin supposed to be used in this case?
As in the dosage, or?
No, it's a liquid. How are they? Are they just swallowing it? How will you advise the patient when you give them the nystatin? Will you just tell them 10 ml 3 times a day, 4 times a day? Have fun. Sam is saying painting on the walls of the mouth. I'm not laughing. It's his emoji. I was expressing his emoji. Yeah, so it's supposed to be used more as a mouthwash. The nystatin, there's a clotrimazole paint, right? It's to be used as a mouthwash. They have to swish it all over the mouth before. Yeah. And then for the esophageal candidiasis, what's the drug of choice, or what drugs do we use for esophageal candidiasis?
Fluconazole.
Ah, yeah, good old fluconazole. Good old fluconazole, yeah. Ah, yeah, the third fungus. Here today, we are covering this fungus. Histoplasma capsulator. Histoplasma capsulator. What does it cause? Where is it found? Shafi told us that Cryptococcus is found in soil. What about histoplasma? What is it associated with?
Pardon, guys.
Histoplasma capsulator. We're asking about histoplasma capsulator. Brenda is saying that they're associated with bird droppings, or that it is associated with bird droppings, right? Like bird, like BIRD, not BAD. Bird droppings, such as the birds.
It usually causes pulmonary symptoms like a non-productive cough.
Mm-hmm.
Yeah.
Yeah, nice. Yeah. Usually this
I think it's
pulmonary symptoms.
I think it's both bad and but
Yeah,
both of
but
them.
both bad and but, not but.
Yeah.
But yeah, that's true. And then Hirala said, yeah, mostly you'll see them with the patient will present mostly with respiratory symptoms. Anything else? Or how do we treat?
It's a dimorphic fungus.
Dimorphic. Dimorphic. By dimorphic, you mean it can exist in two forms. Which form and which form?
I don't know about that.
Someone can fungus, meaning two forms, two morphological forms, which is the first form and which is the second form.
There is a mold form and a yeast form.
Yeah, nice. There's a mold form and a yeast form.
The mold form, it's in the environment and exists as a filaminous fungus, appearing as a mold with separate septates. And then it's found in the soil.
Mm-hmm.
The spores are released into the air when contaminated soil is disturbed. And in the yeast form, that's also the host tissue. Once it's inhaled by the body or the animal, especially in the lungs, the fungus transition to its yeast form. So the first form is in the environment, and the other form it's inside the body. So the yeast form it's found inside the body, particularly within the macrophages. The yeast eggs are oval and round and reproduce by budding.
Nice. So fine. How do we treat histoplasmosis?
Itraconazole, amphotericin B, fluconazole, depending on like infection severity, I think. I don't know.
Yeah. The infection is not so bad. You can give an azole. If it's serious, you give the ampho-B. Then generally all we've said blastomycosis. So but blastomycosis is I don't think it's associated with bad or bad droppings. I think that is what is different when it comes to histoplasmosis. Otherwise, same, the symptoms they'll cause are typically the same. Yeah. Unless someone has something unique to add on blastomycosis. Anyone? So we move. The cause of diaper rash has already been said. So Candida albicans. Nini, how do we treat diaper rash? This is a very common thing. The child is having some redness on their gluteal region, on the region where they have a diaper on. So how do we treat diaper rash? Anyone? How do we treat diaper rash? What were locum community pharmacies? I'm sure you've treated diaper rash. What did you give? What did you give? What advice? Even the advice, what advice did you give? This is a good example of a photo of a child with the diaper dermatitis or diaper rash. So what do you give? A mother has shown you this. What do you give?
You advise on exposure. And then you also advise on cleaning with some warm water, like after every diaper change. And then the combination oil of zinc and castor that you apply after every diaper change as well. Then there's also another one called pseudo cream. I don't know the components of the content in the cream.
Yeah, pseudo cream, yeah.
Yeah.
Yeah, Brenda is also mentioning that antibiotics such as the topical clotrimazole and nystatin when it's severe. Yeah. Yeah, so this is a pseudo cream. Someone will tell us the components of the pseudo cream. Yeah, I believe Sophia has covered everything on diaper rash, unless someone has something to add. We move. Which one of the following compounds does not exist as a cis-trans isomer? Okay. Which one does not exist as a cis-trans isomer? Watu wa chemist. Samiha, which one does not exist as a cis-trans isomer? Is in choice B, because when you arrange the various compounds from choice A and D, there are 2 methane molecules on one side and CH and CH3 on the other. Hence, it cannot exist as a cis-trans isomer. Anyone else with a different opinion or or a different view explanation? Everyone is saying choice B. Last, I think in a previous discussion, we've had someone summarize the different types of isomers: constitutional isomers, geometric isomers, the diastereoisomers, and enantiomers. So we won't again repeat what we've covered before. The last question, then we meet at 8. Dehydration of alcohol produces, okay, has already told us that it produces alkenes. And they're texting me, they're saying that they are 100% sure that the dehydration of alcohol produces alkenes. So unless someone has something to add, we can stop the discussion, take the 1 hour break. We meet at 8 to continue from number 43. Yeah, so from the questions here, get ready for a lot of chemistry in the evening session.